thank you for inviting me. I'm really happy to be part of this wonderful event. I'm happy to be able to give my experiences actually to you. Yes, as Catherine said, I'm a radiation oncologist at the Institute of Oncology for 30 years, dealing with children with cancer and with adults with rare tumors. And 30 years, I am a part of the team of long-term follow-up as well at our Institute of Oncology. It's not easy to give talk after such impressive talks of my colleagues. But I wanted to illuminate a little anyway radiation-induced late sequelae, because I'm a radiation oncologist and I'm causing these late sequelae, which are very important in long-term mortality as well. I would like to say something about radiosensitivity of organs in childhood, those dependencies of this radiation-induced late sequelae, and about continuous care, of course, of these childhood cancer survivors. Pathogenesis of radiation-induced late sequelae is really a complex cascade of events involving different tissue. This is organ parenchyma, vasculature, connective tissue, and local immune system response, causing at the end progrediente fibrosis and organ cell depletion and cell loss. And this radiation-induced somatic late sequelae are mostly dose-dependent, and the latency time is inversely related to radiation dose. If you look at the radiosensitivity of organs, if we compare children versus adults with endpoint of damage of these organs, we can see that most of the organs are more susceptible for this long-term sequelae of irradiation, as you can see in red. But for example, lung, ovaries, and bone marrow are less radiosensitive than in adults, and neuroendocrine, thyroid, kidney are the same. But as I already told, late effects of organs, tissues are dose dependent, as we can see here in and cardiovascular, yes, this is very important. Late sequelae, actually, the most important cause of late mortality among somatic late sequelae are heart damage, and this is dose dependent. Then central nervous system as cognitive defects and causing stroke. Neuroendocrine sequelae are among the most frequent, and this is because of irradiation as well. Growth hormone deficiency being the most frequent, with coming after low dose, actually after 18 or more. And then with high dose comes gonadotropin deficiency, TSH deficiency, and but ACTH deficiency can occur after smaller doses as well, and it's very important, actually, life-threatening condition. Then musculoskeletal growth can be affected with dose around 20 grays. Pulmonary depends, of course, of the volume of the lung involved, and then digestive system and genitourinary kidney can be affected with the dose around 15-20 grays. We can see here growth hormone deficiency is coming actually early after irradiation, in first years mostly, and is dose dependent, as we can see. The peak of growth hormone level is dropping more prominently with higher doses, and of course with the time of follow-up. Yes, damage of spermatogenesis. This is really problematic, not just because of the irradiation, but also alkylating agents, as we heard yesterday. But really small doses of irradiation, and this could be a scattered dose if we irradiate lower abdomen, can cause oligoazoospermia. So we have to be careful with testicles when we irradiate a child. And hypothyrosis as well is dose dependent, as we can see here, proportion not affected being lower with higher doses, and of course with years of follow-up. Heart damage, as I said, very important, somatic late sequela causing late mortality as well. And as we can see here, coronary heart disease is dose dependent as well, and is growing with the time of follow-up. We see here the mean heart dose. If it's more than 35, this is really high, cumulative incidence of 25%. So really important. Late sequela lung damage as well is going up with the dose to the lungs. And of course, we have lung fibrosis, pneumonitis. Cerebrovascular insult, we saw this graph yesterday. Lars showed us this, but it's really important to know this. Yes, 1/4 of long-term survivors are, after many years, can have this cerebrovascular event after being irradiated for brain tumors, as we can see here on the high curve. Second, primary cancers are really our pain, I must say, in our follow-up clinics, because we are losing our patients we know for so many years. And and this is the most important cause of late mortality in our survivors. And if we look at the radiosensitivity of organs, if the endpoint is second malignant neoplasm, we can see that if we give irradiation in first years of life, then they are more prone to develop leukemia, brain cancer, skin cancer, thyroid cancer. If we irradiate in the puberty, then to the breast or uterus, then these cancers comes more frequently than in other time of life. But lung cancer, for example, not those who are irradiated in adulthood are more prone to develop this kind of cancer. Digestive are the same through all this lifespan, but most solid cancers, as we can see here, are more often develop if patients are irradiated in their childhood. Cumulative incidence of second neoplasms is in 5-year survivor of childhood cancer. This was a CCSS study, American study. We can see that, yes, the incidence of all second neoplasms is growing with the time of follow-up, being around 20% after 30 years. But of course, we have some non-dangerous ones, as is non-melanoma, skin cancers, and meningiomas. But if we look at this second malignant neoplasm, we can see here that this proportion is high as well, being around 8%. And of course, if patients are irradiated, these tumors are higher in the frequency. We saw this graph as well yesterday. So risk of second cancer is higher with higher radiation dose, with exception of thyroid gland because of the cell killing effect. And very important, high risk of second breast cancer after mediastinal RT as we can see here, it's really high. It's 30% after 30 years of follow-up in those who were treated with irradiation to the mediastinum in the puberty, but not in those who were treated under the age of 9. And we can see here that the cumulative risk to get breast cancer after irradiation in puberty is actually the same as in those who are BRCA1 carrier. So screening is very important. Risk of colorectal cancer after abdominopelvic RT is high as well, especially if patients are getting alkylating agents as well. As we can see here, those who had irradiation to the abdomen or pelvis had really high incidence, cumulative incidence, which is comparable with those from the general population who has more than 2 first-degree relatives with colorectal cancer. So we started with screening of these second malignancies as well. Cognitive decline after brain RT, this is our pain as well, of course, and we want to omit this irradiation, but sometimes it's not possible, of course, because of this highly malignant tumor of the brain coming in first years of age as well. And it's very important when we irradiate our patients, if they're smaller, we see here 5 years of age, this decline is higher after irradiation, for example, for low-grade glioma of 54 grays, than in those who are of higher age. Then I want to tell something about our role as radiation oncologists. Yes, actually we are in this circle of our childhood cancer patient. Actually, when patients are at treatment, we are seeing our pediatric hemato-oncologist on weekly basis. On multidisciplinary team meeting, we go there to pediatric clinics in Ljubljana, and we're discussing treatment of our patients together. Then of course, we irradiate those children who need irradiation. 30 or more years ago, it was around 70% of childhood cancer who needed childhood cancer patients who needed irradiation. Now this proportion is around 30%. We are happy for this, but anyway, we still need to irradiate some patients. And then, of course, this transfers goes really smoothly from these pediatric clinics to our clinics at the Institute of Oncology, where we give these patients, survivors, long life follow-up. And of course, we are getting so important and precious knowledge about late sequelae, enable us to further reduce this late sequelae with reducing the dose to organs at risk. So I think we are really in this circle, and we have an important role in long-term follow-up as well. Of course, we saw this yesterday. These guidelines are so important. I'm so happy to have these guidelines because these are our national guidelines as well now. So yes, we are following these guidelines, of course, as national guidelines. And we give follow-up care at our institution, preventive investigation for somatic late sequelae, screening for second primary cancers, health, lifestyle, and self-examinations, very important, psychosocial support, research, education, empowerment. So all this, what we heard before. And we have population-based follow-up clinic for all Slovenian survivors at our institution from 1986, established by Professor Berta Djereb. She was a radiation oncologist, and she was told as a pioneer of pediatric radiation oncology as well by PROS. We are doing this from for almost 35 years now. And as I told you, every cancer survivor is transferred from pediatrics to our clinics, from one beautiful building to another. Of course, it's not easy, but with all survivors, but we struggle with this. And this is our team of radiation oncologists and our nurse. Of course, we don't have such a big team as at Princess Maxima Center. We are small. Slovenia have only 2 million inhabitants, and we have around 1,500 survivors. But it is population-based, it's very important. And of course, we are all radiation oncologists doing pediatric radiation treatment as well. I just want to show you how important is lifelong long-term follow-up. As you can see, after treatment of brain tumors with irradiation, you can get ACTH deficiency as late as 35 years after irradiation. So it's really important, and this is a life-threatening situation, so we need to follow our patients lifelong. Breast cancer screening, we are doing this for 25 years, and we really find really small T1 cancer, except in one who was diagnosed before screening. So really important to have this screening. And we started with colorectal cancer screening 6 years ago, and we found in our population who had abdominopelvic RT these adenomas who are precancerous lesions in 2/3 of them. So really important finding. We also give psychosocial support with our psychologists on monthly meetings in groups for survivors who want this. And we also have Foundation Little Night to offer this psychosocial support. The other thing I want to say, as Ricardo mentioned yesterday, sometimes it's not easy to find out what some organs get during irradiation, especially in those who were treated 20, 30 years ago. As we can see here, these charts from more than 20 years ago. So we more easily found out and anticipate this and help, because this is very important to know what kind of follow-up must be offered. But with modern RT plans, it's easier because we have here doses to different organs at risk, as you can see here. And as I say, this knowledge about late sequela is very important, as we discussed yesterday as well. So we really want to lower the dose to the risk organs, and this modern planning technique, CT planning, protons, enable us really to lower this dose to some critical organs, as here to the dose to spinal cord, for example, larynx, and here the plan with protons. And we are happy that we are sending our patients for example, cerebrospinal irradiation to proton center. As you can see here, the doses to abdominal organs and thoracic organs can be avoided with proton treatment. So this is really important. But as Helena already said, and Emma said, this is a teamwork. I can say that radiation oncology is important player in long-term follow-up, but this is a teamwork, and we have to do it together to be better in doing this. So I would like to thank you, and this is hello from Ljubljana. Thanks.